In this presentation, an intraarticular fracture of the distal radius will be treated with a 2.4 variable angle LCP volar 2-column distal radius plate. The objectives of this presentation are to identify the clinical indications for pulmar plating and preoperative planning, to show the principles of the variable angle locking system, the patient position and the approach, the instruments needed, the approach on the bone model, and the reduction and fixation of the fracture. The indications for pulmar plates in articular fractures are a hyperextended pulmar fragment and/or loss of pulmar buttress, reconstruction of the radiocarpal joint, Colles-type fractures, and Smith or reverse Barton's fractures. Be aware that through a pulmar approach, visualization of the joint surface is not possible, as opening of the capsule would lead to some carpal instability. This is an example of a complex distal radius fracture. An external fixator was mounted and a CT scan was performed. It can be seen that some fragments on the pulmar side could not be reduced under traction. Therefore, a direct approach to the pulmar fragment is needed. The variable angle locking screw and the standard locking screw are shown. The head of the variable angle locking screw has a rounded shape, whereas the head of the standard locking screw has a conical shape. The design of the plate hole in the head of the plate allows the variable angle locking screw to be inserted up to 15 degrees off-axis in all directions. The variable angle locking screw can also be inserted at a fixed angle into the threaded portion of the combi plate holes. The standard locking screw can only be inserted at a fixed angle and only in the threaded portion of the combi plate holes. To drill off-axis holes at the desired angle, the funnel-shaped end of the universal variable angle locking drill guide is used. The drill guide tip is inserted coaxially into the cloverleaf design of the plate hole. The tip of the drill guide must remain fully seated in the plate hole while drilling. The funnel of the drill guide allows the angle of the 1.8 mm drill bit to be varied as much as 30 degrees. The fixed angle end of the drill guide only allows the drill bit to follow the nominal trajectory of the locking hole. The plate is available in a left and right version. For the pulmar approach, the patient is placed in a supine position with the arm abducted and fully supinated. The C-arm must be placed to obtain adequate images when needed. The landmarks are located and marked. Usually, it is easy to palpate the radial styloid. Here is the flexor carpi radialis tendon. This is the radial artery. A longitudinal incision is made slightly radial to the flexor carpi radialis tendon. Here is the flexor carpi radialis, which has its own sheath, separate from the other flexor tendon sheaths. First, the tendon sheath of the flexor carpi radialis is opened. The next layer would be the forearm fascia. Now the forearm fascia is split, and here is the muscle belly of the flexor. The muscle belly of the flexor is moved towards the ulna. This is the radial border of the pronator quadratus. Here is the radial shaft. This is the pronator quadratus, and now we dissect up toward the radial styloid. This is the Nelson's watershed line of the radius. Now we dissect towards the pulmar ulnar side. The next step is to release the pronator quadratus from its radial insertion. Later, 2 stitches are placed to reattach the pronator quadratus at this level. Usually, it is not possible distally. Here are the fibers of the brachioradialis tendon which can be released. Step by step, the fracture becomes visible. By placing the retractor this way, the pronator also protects the median nerve. This is the shaft component. Here is the radial styloid, and this is the palmar ulnar fragment. It is important to leave the palmar wrist capsule intact to avoid devascularization of the fracture fragments and destabilization of the palmar wrist ligament. The instruments needed to insert cortex screws are the 2.4 universal drill guide, the 1.8 mm drill bit, the depth gauge, and the short T8 star drive screwdriver shaft and handle. The instruments needed to insert the locking screws are the threaded 2.4 LCP drill sleeve, the 2.4 universal variable angle LCP drill sleeve, the 1.8 mm drill bit, the short T8 star drive screwdriver shaft, and the 0.8 Newton-meter torque limiting attachment with handle. The 1.25 mm plate reduction wire with small stop is useful to hold the plate in position on the bone. The model is placed as shown. The landmarks are the radial styloid and the radial artery of the flexor carpi radialis tendon. A longitudinal incision is made slightly radial to the flexor carpi radialis tendon. The dissection is made between the flexor carpi radialis and the radial artery, exposing the pronator quadratus. The pronator quadratus is detached from the lateral board of the radius and elevated towards the ulna. For the model, a second retractor can be helpful. The fracture is reduced using the preferred reduction technique. The reduction technique will be fracture-specific. The plate is positioned on the extraarticular palmar surface to judge the position of the plate relative to the distal fragment. The first screw to be inserted is a cortex screw applied through the elongated hole in the plate shaft to allow a later adjustment of the plate. The 1.8 mm drill bit is used for a 2.4 mm locking or cortex screw. The 2 mm drill bit would be used for a 2.7 mm cortex screw. The depth is measured with the depth gauge. A 2.4 mm cortex screw is inserted with the T8 star drive screwdriver. The plate position should be checked under image intensification. The plate position is adjusted if necessary and the screw is retightened. the anatomically pre-contoured plate is used as a reduction template. The articular block is reduced to the plate using either direct pressure or a dorsally placed pad and temporarily fixed in place by two 1.25 mm K-wires. If necessary, 1.25 mm plate reduction wires can be inserted through selected K-wire holes in the plate to temporarily fix the plate distally. The threaded 2.4 LCP drill sleeve is screwed into the most proximal plate hole and a 1.8 mm hole is drilled. The depth of the hole can be read off the scale on the sleeve and the mark on the drill. The drill sleeve is removed and a 2.4 mm locking screw of appropriate length is inserted using the short T8 star drive screwdriver shaft and the 0.8 Nm torque limiting attachment with handle. To drill off-axis holes at the appropriate angle, the funnel-shaped end of the universal variable angle locking drill guide is used. The funnel allows the angle of the 1.8 mm drill bit to be varied as much as 30 degrees. The depth is measured with the depth gauge. The appropriate length locking screw is introduced. To insert a variable angle locking screw at a fixed angle, the 1.8 mm drill bit is used with the fixed angle end of the drill guide. This end of the drill guide only allows the drill bit to follow the trajectory of the locking hole. The depth of the hole can be read directly from the mark on the drill and the scale on the drill guide. In this case, 26 mm. The appropriate locking screw is inserted. In order to fix the radial styloid, the most radial screws should be directed distally and radially as needed. The remaining plate holes in the head of the plate are filled as necessary, either at a variable or a fixed angle. The reduction forceps and the K-wires are now removed. In a clinical setting, several X-ray views of the distal radius are taken to ensure correct alignment and reduction. The screw placement and length must also be confirmed. Additional views, such as 10 degrees dorsally tilted, 20 degrees inclined lateral, and 45 degrees pronated oblique, ensure that the distal screws are not in the joint. The 1-year follow-up X-rays show anatomical consolidation of the fracture. This presentation has demonstrated the clinical indications for pulmar plating and pre-operative planning, the principles of the variable angle locking system, the patient position and the approach, the instruments needed, the approach on the bone model, and the reduction and fixation of the fracture.